USAID, the Water and Sanitation Program at the World Bank, and the Water Supply and Sanitation Collaborative Council. You can find more information about our organization at globalhandwashing.org, where you can read more about our members and then also find information about joining us. So the objective of this webinar is to explore how innovative water sanitation and hygiene interventions, specifically handwashing behavior change programs, played a critical role in halting the Ebola crisis and promoting ongoing community health. We're also going to assess how lessons learned from this crisis can be incorporated into other programs implemented by the WASH sector to promote sustained behavior change. So really, our goal is to look at what was done, what was successful, and see if there's lessons that we can learn from fighting Ebola that could be applied towards future outbreaks, as well as strengthening health systems more generally. So, as way of background, there were nearly 29,000 reported cases of Ebola and over 11,000 fatalities between December 2013 and April 2016. The Ebola crisis triggered an unparalleled global response because Ebola primarily was a disease that had plagued the African subcontinent, but with the outbreak in late 2013 and 2014, Ebola became a global threat. And despite the fact that hand washing with soap, sanitizers, and bleach can effectively remove the virus from skins and surfaces, stigma around Ebola and poor understanding about its prevention were some of the main reasons that it was transmitted so widely. It's also worthwhile noting that unless long-term WASH practices are sustained, that Ebola still does pose a threat to the people of Sierra Leone, Liberia, and Guinea. So there really is a need for kind of ongoing promotion of WASH. In March of 2015, Liberia was designated as Ebola-free, and the same status was given to Sierra Leone and Guinea shortly after. But Ebola cases continued to be reported until as recently as June of this year. And so while Ebola seems like it's far in our rearview mirror, it's still something that's very much a concern for public health, specifically in the region. So there are no proven treatments, vaccines for Ebola. Instead, there's a range of good practices that are promoted to stop the threat. Improved water sanitation and hygiene practices, and hand washing with soap in particular, coupled with improving community behaviors, engaging with community members around safe actions that they can take when in contact with someone who's died from Ebola, such as safe burial practices, and social mobilization continue to be essential as they were in the initial crisis. So overall, I think that improving WASH and strengthening healthcare systems were really instrumental in not only preventing a relapse of Ebola, but it's also important for being prepared to prevent future global health outbreaks and crises. So in this webinar, as I mentioned, we will hear key takeaways from 3 organizations that were involved in fighting Ebola. They are going to outline their WASH solutions and share how we can learn from their experiences going forward. You can see the presenters here, as well as the organizations that they represent. So first, we're going to hear from global communities about the impact that community-led total sanitation, often called CLTS, played on helping to contain and prevent Ebola. They're also going to discuss how CLTS can lead to long-term hand washing and hygiene behavior change. Oftentimes, hand washing and CLTS are integrated, which is a good, effective way to promote both. Then we'll be hearing from UNICEF, this presentation will outline the impact of hygiene kits that were distributed in schools in fighting Ebola and what schools were reopened. We're also going to hear about how UNICEF continues to incorporate the lessons that they learned from the Ebola response into their response to other infectious disease outbreaks. And then last but not least, we're going to hear from the U.S. Centers for Disease Control and Prevention. Dr. Chea will speak about the Infection Prevention and Control Program and how improved WASH interventions were innovative, drove the program's success, and takeaways and evidence can be replicated to prevent future outbreaks. And then at the end, we are going to have some time to open the floor to the participants of the webinar. And really, we want to focus in that point on where do we go from here. So both looking at what did we learn, but then how can we catalyze action going forward. So with that, I will hand over the mic to Global Communities.
Great, thank you, Hannah. Can you all hear me?
Yep, we can hear you great.
Great, thank you. So just to give you a little bit of background briefly, Global Communities is an international NGO, and we're operational in about 25 countries worldwide. We're based in Washington, in the Washington, D.C. metro area, and we've been implementing programs for more than 60 years across sectors, including economic growth, WASH, food security, and governance. But the core of our work is really community engagement and community-driven development. Next slide, please. Great. So Global Communities has worked in Liberia for more than 12 years, beginning with work to reintegrate ex-combatants. We've supported women entrepreneurs, provided shelter, and grew small businesses. But in 2010, Global Communities began implementing the USAID-funded Improved Water Sanitation and Hygiene Program, or IWASH. And the 5-year, $10 million program was a comprehensive WASH program founded on the community-led total sanitation methodology. And for those not familiar, CLTS is a globally recognized sanitation promotion methodology that uses community momentum to eliminate open defecation through a rigorous triggering and monitoring process. And as Hannah mentioned, that's very often coupled with other activities such as the promotion of hand washing. So communities end open defecation by various means, but most importantly by building latrines that are provided no subsidy. And in Liberia, when we were working on the IWASH program, sanitation coverage was as low as 12 to 15%. And we worked in some of the rural counties of Bong, Lofa, and Nimba. Next slide, please. When Global Communities first started this implementation in 2010 of CLTS, we actually saw rather slow progress. Communities were slow to adopt open defecation-free behaviors, and the triggering and monitoring process was done almost exclusively by program staff. So this was quite expensive and quite inefficient. And so the government of Liberia at the time also did not have a national or decentralized structure in place to coordinate CLTS, or really any effective environmental health programming that was, accessible at the local level. And without monitoring, communities, made little progress. So as a result, Global Communities concluded that we needed to build a more sustainable structure that would help to have more intensive local engagement. Next slide, please. So to do this, we first broadened the definition of ODF to include community brushing, things like garbage pits, encouraging households to use clotheslines and dish racks, as well as hand washing stations. And this ensured that the benefits gained from ODF status went further with these additional environmental health actions. Second, we developed localized hardware solutions. And it was actually quite exciting because a lot of this was done alongside community members themselves who came up with easy, all local material solutions for latrine designs as well as hand washing stations. And so the results were a slabless ventilated improved pit latrine that reduced the risk of the floor collapsing, as well as the reed-based hand washing station, which is pictured in the slide, that could be made quickly and simply and with readily accessible and low cost or free materials. Third, we worked closely with the Ministry of Public Health, the Ministry of Public Works, and the Ministry of Internal Affairs to integrate CLTS into their existing administrative and, very importantly, traditional leadership structures that strengthen the capacity of staff, particularly environmental health technicians. And then fourth, we triggered communities in clusters, and this allowed for a sense of mutual reinforcement and friendly competition. And finally, our most important adaptation of CLTS was the development of the Natural Leader Network. We built on the use of natural leaders in the CLTS process that is standard in CLTS as they guide their communities to ODF status. But the network brought successful natural leaders together to go on to trigger additional communities. So they received modest incentives for successfully bringing communities other than their own to ODF status. And this significantly reduced the implementation cost and also activated a network of capable environmental health champions in the communities. Next slide, please. So before Ebola, about 84% of communities triggered under IWASH achieved ODF status, and of that 84%, about 85% maintained that status for 1 year, and this was done without subsidy. But while these were encouraging results, it was limited to some 300 communities over the life of the program. Next slide. Thank you. So when Ebola hit, global communities was actually winding down our IWASH activities. However, we saw an urgent need for quick action to both provide IPC supplies and to communities, as well as spread health messaging. So we were working very closely already with environmental health technicians and traditional leaders that were engaged during the CLTS process, as I discussed earlier. And we worked with them to activate the Natural Leader Network to deliver supplies and messaging. This proved successful at a time when, as we all know, there was very high suspicion of health workers, because natural leaders were already a trusted source of information in their community, and they had earned respect in their communities for helping them to achieve ODF status, which is a very, visible result. And they were from the communities that they served. They knew the local languages, the context, and the personalities involved. And in addition, we worked closely, as I mentioned, with environmental health technicians who were already in place, able to provide a higher capacity or a higher level response than before, and they had been better integrated into the health system through CLTS implementation. And they were very key in our other Ebola response efforts, such as DBM, dead body management, and contact tracing, etc. Next slide, please. So this is where we ended up having some very interesting and unintended results related to how our WASH programming was effective in further Ebola response. As natural leaders were deployed in Bangladesh and Nimba counties during the height of the crisis, they were working in, as you know, some of the hardest hit areas. And we received somewhat surprising results, and that was that none of the communities that achieved ODF status reported any cases of Ebola. So I should, give the disclaimer that this was reported cases, but we did then solicit an external study to verify this through using a representative sample. And the study did find that 100% of the ODF communities, again, sampled, did in fact remain Ebola-free, even when neighboring communities were very hard hit. And in addition to that, 73% of general program communities, so that would include both those that did achieve ODF status and those that did not but were still part of the IWASH program, remained Ebola-free. And that was compared to 24% that were not a part of the program at all. So of course, this wasn't an RCT and research was done after the fact, but it definitely suggests that CLTS overall is effective in raising community awareness of health practices, and we think increased reception of Ebola messaging. Next slide, please. So what have we seen post-Ebola? First, there was a very significant increase in demand for CLTS programming coming directly from communities. They saw how their ODF neighbors had fared better during the crisis, and so global communities increased triggering, manyfold, and has since triggered more than 2,000 communities since we're using post-Ebola as spring 2015. Granted, there were other cases after that, but once the initial high caseload had wound down. And so since then, our ODF achievement rates are still high at about 70%, and we anticipate that will increase because verification is ongoing. Next slide, please. We've also seen that more communities are attaining ODF status at a faster rate, and we believe that this is a combination of post-Ebola momentum as well as increased inefficiencies more broadly in the CLTS framework in Liberia, as we've refined it over time and worked closely with the ministries I mentioned earlier to really engage them to help improve both the sustainability and the efficiency. In the past, communities could take as many as 200 days to achieve ODF status, and we are seeing that now they are taking sometimes as few as 40. Next slide, please. So in conclusion, and most importantly, we've observed several key lessons related to the importance of innovative WASH programming as it relates to Ebola and broader disease prevention. First, CLTS can be effective beyond its initial goal of bringing communities to ODF status. We've seen that good CLTS generates very impressive momentum at the community level, and that momentum can be harnessed for other health and development objectives. Second, natural leaders and their CLTS communities should be involved in other health programming. During the Ebola recovery period, the government of Liberia has instituted the Integrated Disease Surveillance and Response System that focuses on identifying, reporting, and preventing key priority diseases that include Ebola. And so Global Communities has continued to work on some of this programming, and we also with CDC's support, and this has involved natural leaders and CLTS communities in other public health programming related to IDSR and community event-based surveillance. So communities are more educated about priority disease prevention and response. We've worked with this in 2 different programs where we connect natural leaders to community health volunteers and health facility staff to increase the linkages between the formal health system and informal community groups. This has improved the dissemination of health messaging, and it's been broadened from Ebola to also include polio and measles vaccination campaigns, cholera prevention, etc. And this really helps trickle down information from the ministry level to communities. And then finally, prior to Ebola, community level health interventions were receiving less attention, and this weakness was certainly exposed by the Ebola crisis. And we think that CLTS and natural leader engagement and other health-related activities such as surveillance, social mobilization, vaccination campaigns, MCH, etc., has given its due more targeted support to the community level in a health system that's still really trying to develop in a sustainable way to manage these lowest level of community health actors. So we think CLTS has been critical, and particularly the evolution of natural leaders' activities in making communities themselves more self-sufficient in the absence of technical and financial support from the formal health system. And we think that natural leaders really can be the eyes and ears of the health system at the most local level. Of course, working closely with community health volunteers and the systems that the government of Liberia is looking to roll out as we move forward. So overall, we see great potential to continue to leverage CLTS and the natural leader network as a health solution beyond WASH. Thank you.
Great, thank you so much. There are 2 questions in the that I wanted to bring up just since we're, I think they're relevant, and then we will have the broader Q&A later. But can you just describe how many communities you reached as well as the definition of ODF that you're using?
Yes, the definition of ODF under the government of Liberia policy includes the absence of evident open defecation, and then also the observance of communities having those other health-oriented activities or products. So that's dish rack, community brushing, and hand washing stations. And verification is done over a shorter period of time once the community and the natural leader has said that the community is open defecation free. Then there's the National Coordinating Council for CLTS through the government does the verification, and then it's after a period of 1 year that certification is done.
Okay, great.
I'm sorry, what was the second question?
How many communities were reached?
So we worked with 351 communities under the IWASH program that achieved ODF status. And since then, we've worked with well over 2,000 communities overall. Right now, we've triggered 2,124 communities post-Ebola for a total of 2,476.
Okay, great. We'll do more questions later on. So now we will turn to UNICEF to describe.
Thank you. So we will talk about developing innovative wash, and in particular the handwashing package during the Ebola outbreak. So next, please. So we will talk about the fact that Ebola was new for all of the actors and that we were fighting the unknown. So we had to develop the appropriate WASH packet in general, and there was a lot of debate on hand washing and the type of activity we should undergo to respond to the outbreak. And finally, the impact and the lesson learned of this period. Next, please. So this Ebola outbreak affected 3 large countries in West and Central Africa, and there was also sporadic cases in other countries such as Nigeria and Senegal. WHO declared Ebola as an international public health emergency on the 8th of August, and UNICEF activated its level 3 corporate level on the 30th of August 2014. So the situation for WASH practitioners was that there was no guideline for responding in a large scale to Ebola, and there was a lot of fear to intervene in such a context because of the media frenzy. So we can see that as the level 3 was declared, a lot of cases were happening in Guinea, Liberia, and Sierra Leone, and there was a lot of anxiety from practitioners. Next, please. So this is just to give the overall picture of the Ebola. As June 2015, we had more than 27,000 cases with 11,000 deaths, affecting mainly Sierra Leone, Liberia, and Guinea. And most of the practitioners agreed that there is a fair underreporting in those data. Next, please. So how did we organize the sector as a WASH lead agency? What was different from most of our outbreak response, which is mostly, our experience is mostly concentrated on cholera or diarrhea disease, is that we put a lot of emphasis on WASH in health, which means the provision of WASH facility inside the Ebola center to ensure appropriate case management as early referral containment of patient is the key behavior to reducing the outbreak and finally ending the transmission. So we went from focusing on providing the appropriate WASH facility in the Ebola to ensuring prevention measure in non-Ebola health facility, affected household where there were Ebola case, quarantine community, and then general public at-risk community, school and public place, which were about 100% of the 3 affected countries. Next, please. So WASH in Ebola Center was primarily the provision of drinking water, sanitation, and hygiene and disinfection. Which is particular to Ebola cases is that hand washing was included as a component of infection prevention and control and was managed by medical staff, as there was a red zone in Ebola Center, which means that you could only go inside fully dressed with the appropriate suit. So there was a very big difference compared to cholera center, for example, where you can go as a WASH specialist in and out of the center. This was not possible for WASH practitioner to enter Ebola center without being suited up appropriately. WASH in health facility, the focus was on hand washing with chlorine and soap and the provision of protective material. In affected household, the focus was also on the no-touch policy, IPC control, and hand washing with mostly with chlorine and prevention messages. In quarantine community, the sector concentrates on the provision of emergency wash item, as well as handwashing guideline, mostly with chlorine and soap. Next, please. So washing community. This was also something we had to develop together as a sector, as there was not any guideline for how to do, what should we do in WASH community, what was the priority, should we do latrine, should we do drinking water. Finally, the main activity in community, not directly quarantine, were activities of promotions, preventive and protective behavior. The key behavior targeted were the no-touch policies and the prevention messages around the burial, safe burial, and washing with soap. There was door-to-door, there was mass campaign for all of the protective behavior, and specifically in Sierra Leone, there was what was called a stay-at-home campaign, where the whole country was in a sort of stay-at-home, not to say lockdown, where hygiene promoter and social mobilizator will go to all of the household in a 3-day period to give preventive messages, as well as a bar of soap. For WASH in school, what is important to say is that this activity was late in the outbreak, as all of the schools in Guinea, Sierra Leone, and Liberia were closed. So the discussion was engaged beginning of 2015 to develop a protocol that will ensure that kids could go back safely to school. So all of the partners around the Ministry of Education developed safe school protocol. It was also important to ensure that this protocol could be followed by all of the schools. So there was a countrywide distribution of supplies, dissemination of IEC material for children, for teachers, and finally engaging the Ministry of Education into a very tight monitoring of the safe protocol implementation. I think what is important to mention at this stage is that WASH is a supportive area for this outbreak. Health is in the lead with case management, early referral, no-touch policy were key behavior to change, and handwashing was a contributing factor. But contrary to, for example, cholera, the importance of this behavior toward reducing the transmission is less clear than for oral fecal disease. Next, please. Oh, sorry, what is the no-touch policy? The no-touch policy means that basically you should stay away from any individual, including your family, your colleagues, and for a practitioner it means that you should not touch people, like you don't greet people, you don't hug people, you don't do community meetings, so you try to stay 2-3 feet away from anybody. So this is the no-touch policy. Next, please. So handwashing, there was quite a big debate between practitioners, especially in the beginning of the at-scale response, which will be dated around September, November 2014, where after the declaration of the L3 activation. So should we promote handwashing knowing that it's not the key protective behavior, or concentrate in the no-touch policy and burial protocol, early referral, since it might give a wrong sense of security? Meaning it's not because you wash your hands. If you have someone that is ill in your family, you should not touch him, rather than touch him, help him, and then wash your hand with soap. So there was a debate on this. What about what should we use? What should we promote for hand washing? Should we promote only chlorine? Should we promote soap? Is there a difference of promotion depending on the location for health center, for school, for community, for affected community? Should we change the message? Would it be difficult for people to perform hand washing with the right amount of chlorine if we choose chlorine? What is the availability in rural area of chlorine or soap? And what is important was also to know, if we choose to promote only chlorine, does it has a risk that soap is being perceived as not effective for the future and endanger years and years of hand washing with soap promotion? Who should do hand washing promotion? There was a lot of debate, and with the scale up, there was the creation in most of the country of a social mobilization pillar, which was really new to our conception of the cluster and the way we are usually organized. So it was a bit difficult to adapt to this new pillar system when we are quite used to the cluster system in an emergency. So it was difficult, for example, for WASH practitioner to know exactly where to fit in the IPC, in the case management, in the social mobilization. And for a few months, there was a missing link for the WASH partners to know where to refer and where to coordinate and who to coordinate with. And finally, how should we do this promotion of behavior since we cannot do a community meeting? Is it safe to send social mobilizator, hygiene promoter to community, and should we endanger them by sending them to household and affected household? So those are a lot of the questions that were discussed in the beginning of the outbreak in the context of where little is known about what we should do and what are the risks. What are the risks? Next. So despite those debate, activity were implemented in Sierra Leone is just an example, as most of the activity were also implemented in the two other most affected countries. So hand washing in Ebola and health was promoted as a component of infectious prevention and control. It was done by medical personnel, as no other personnel could enter inside the Ebola center, and it was with the exclusive use of chlorine, and it was mandatory for everybody entering the center. And washing in public place was also done in official building, in checkpoint, in supermarket, mostly with chlorine. And it was also monitored, so I put mandatory, but there was a staff in most of the public building. There was checkpoint when you change district, and there was hand washing station in front of every supermarket and in a lot of the street shop as well. And the hand washing practice was monitored by the hand washing facility attendant. Next, please. Hand washing with soap in community were promoted by using all the personal trained people. So that means WASH practitioners that were used to do CLTS or hygiene promotion were engaged in social mobilization. There were new actors involved, and all the available medias were used. And washing prevention and soap was also used as an entry point to introduce the other behavior. And this link between the hygiene promoter and their community they used to work on was extremely important to build confidence in a time where community had a hard time believing authority, government in general, and the climate of fear and distrust was extremely important. And washing with soap in school as part of the Safe School Protocol with the provision of supplies and the creation of this new norm that before entering school, all the children should wash their hands. Next, please. So this is the result of a 3-CAP survey that were done between August, September, and December 2014, and it was done on the key protective behavior. So handwashing with soap is the first one. So we see that, and it's self-declared reported behavior. So we see an increase between August and September, knowing that in Sierra Leone, December, January were the peak of the outbreak with more than 500 cases per week. Avoid crowded places, so this is referring to the no-touch policy. Avoid physical contact with everyone. Avoid physical contact with people that might have Ebola, and do not participate in burial, which are key behavior to stop the transmission of the disease. So we see that there was increase in behavior, that there was a uptick in hand-washing practices, self-reported as a disclaimer, but we also see that the social mobilization on the other protective behavior still needed to improve in order to prevent any transmission. Next, please. So what has been the impact of hand-washing promotion? Well, first we can say that there was an improved knowledge and practice of hand-washing with soap and chlorine. It was very visible during the outbreak with all of these public facilities, but also in household. It was self-declared an increase in practice. During the outbreak, this new social norm was creating, washing hands with soap before entering public places, schools, but also other public buildings, health center, of course. What is the contribution of hand washing in ending the outbreak? This is fairly unknown, and it has not been there has not been evidence or assessment of the contribution of this particular behavior in ending the outbreak. And we know that early referral containment are the key to reducing transmission. And I was referring to the earlier presentation we had by Global Community on the evidence that community empowerment does have an impact on protecting communities against disease as they gain trust and adopt more easily other protective behavior. Next. Lesson learned from Ebola. It is extremely important to produce timely guidelines for emerging context. So this was done in October for what should be the WASH package that we discussed earlier, and then it was refined later in November. There was also the Safe School Guideline in February 2015 that was produced by UNICEF. So this framework could be refined and reused for other outbreaks in the future. What we see is that it is extremely important to coordinate the effort to avoid confusion of the message. There was notably some confusion around the use of chlorine and its potential danger for medical staff. So it creates a lot of uncertainty for practitioners and for the population that were receiving those messages, especially in a context where we are not in our usual cluster response that partners are used to. We need to build on the experience of the local actor, especially community development actor, those involved in CLTS and in washing school. So we build on the link between the actor and the community and the trust they have grow over the year. Knowledge management should be improved. We realize late on the emergency that we have not monitored or a lot during the emergency or not sufficiently. Monitoring and reporting were often done at the same time. So it's hard now to build evidence and to look critically at what was done during the emergency. Next, please. Finally, there is some open question, and I think it will be important as a group to discuss them prior to the unfortunate next emergency, especially on what should be promoted and for what type of disease. Should we promote hand washing with soap? Chlorine, as I mentioned earlier, there was a debate around the use of HTH in a regular basis, that it might cause lesion in the skin, which could lead to infection, and some practitioners were recommending, especially thinking of MSF, and the use of NDCC instead of HTH for a chlorine solution and washing. Does it depend on the type of disease or on the, if we want to do the promotion in public place, in household? Who should establish those guidelines? Where can we have this type of discussion? How can we sustain the hand washing social norm created during the outbreak? How do we monitor a social norm? What should we do in those 3 countries to try to build on the unfortunate emergency? And finally, a new question about the coordination of the hygiene promotion subcluster that is currently in the cluster system hosted as part of WASH. If there is a creation of a social mobilization cluster for the next emergency, which has been in discussion, how would we coordinate those 2 entities? It's important to think about it before, so that there is not these first few months that are so important to coordinate the message are not lost. Next, please. This is it. And this is just the IEC material that was done in Sierra Leone for Safe School as part of the Safe School protocol, and happy children returning to school in Sierra Leone after a long time, nearly 8 months, I think, without school. Thank you.
Great, thank you very much for that. I think that's a really thorough overview, and I appreciate the challenges that you faced and the questions you have wrestled with. And I'm glad that you mentioned the debate about using chlorine for hand washing, because that's certainly something that we received questions about as well. So finally, last but not least, we will move on to CDC.
Thanks. Can you hear? Great.
Well, for you to speak up a little bit.
Hello, can you hear me? Can you hear better now?
You sound slightly far away from your microphone, so if you could move closer to your microphone or speak up a little bit, I think that we would hear you a little bit better.
Okay, I'll try to speak up, but I'm having the microphone right in front of my mouth right now. So, can you move to the next slide, please? Thanks. So I'd like to begin my presentation today by giving you a very brief introduction to infection prevention and control. Though the name does not specifically mention healthcare settings, when we say infection prevention and control, most of the times we are referring to the prevention of transmissions that occur in healthcare facilities, such as community health posts, health centers, hospitals, treatment centers, or isolation areas for specific diseases like Ebola. So for disease transmission to occur, there must be a pathogen such as a bacteria, virus, or fungi, and a reservoir for the pathogens to survive. Examples of reservoirs could include soil, animals, humans, or a dirty drain or pipes. In addition, there must be a port of exit where the pathogens can leave the reservoir, such as a wound, vomit, diarrhea, or secretions from a coughing patient. After the pathogens leave the reservoir, it needs to be transmitted to a person. And this could occur through contact with contaminated hands, contaminated equipment or surfaces, through droplets from coughing or spitting, and through the air. After the pathogen successfully reaches a person, there must be a port of entry, such as a cut, a wound, mouth, or nose for the pathogens to cause an infection. I want to also add that not all transmissions would result in an infection. It will depend on the host too. Sometimes the host is vaccinated against that particular pathogen or has strong immunity, so the infection wouldn't occur despite the pathogen successfully reaching the person. Next slide, please. So to prevent these infections, healthcare workers must adhere to standard precautions at all times. And the important elements of standard precautions include hand hygiene, personal protective equipment or PPE, prevention of sharp injuries and injection safety, environmental cleaning, waste management, and disinfection and sterilizations of medical equipment. Next slide, please. Based on my experience working in infection prevention and control for several years, we need WASH for at least 5 of the 6 elements of standard precautions, including hand hygiene, environmental cleaning, prevention of sharp injuries and injection safety, waste management, and disinfections and sterilization of medical equipment. And this became more obvious during the Ebola outbreak response in West Africa. And in the next several slides, I will share experience from West Africa in trying to improve different elements of standard precautions among frontline healthcare workers. And I will try to explain along the way why I think WASH and IPC should work hand in hand in developing countries. Next slide, please. So while trying to improve hand hygiene at triage stations and in the wards, it was obvious to me that alcohol-based hand rub is not the solution due to issues such as high cost, unavailability, and loss if placed outside in the triage station. So the alternative is clean and safe water. But I believe all of you are well aware that access to clean and safe water can be very challenging in low-resource settings. So who could help us improve hand hygiene in these situations? And I believe the answer is WASH. Next slide, please. And this is a picture of a healthcare facility I visited in Guinea. Right after I got out of the car, I walked toward these buckets, hoping to wash my hands before entering the facility. I was disappointed to find out that they were empty and dry. So I ended up performing hand hygiene using my alcohol-based hand rub that I had in my bag. Then I met the director of the hospital, of the facility. I told him I was trying to wash my hands at the entrance to the hospital, but the buckets were empty. So he replied, and he said he knew that, and he relied on a borehole in the hospital for the source of water, but it was completely dry. And he continued that he was using the limited hospital budget to buy water from a local company. But since it's so costly, he reserved the water for use in operating rooms only. And he told me that he had reached out to an NGO in the community to see if they could drill a new borehole for him, and asked me to help follow up. At that point, I think it became more and more obvious to me that WASH and IPC must work closely together in these settings. So before we left the hospital, I asked if I could use his toilet. And he was so kind and let us use his toilet. But as expected, it had not been flushed for weeks. And this, we're talking about the private toilet of the hospital director located in his office. So I think you can imagine what it might be like in patients or regular staff toilets. Next slide, please. Improving environmental cleaning in healthcare settings is another huge challenge. I took these pictures in a university hospital in Conakry. The pictures on the far left is an operating table, and the picture in the middle is the cart in the same operating room, sitting very close to the table. And the picture on the right is a closer look at each shelf. I think the picture speaks for themselves. Again, in this tour of the hospital made me more and more convinced that I must talk to my WASH colleagues. The hospital hygiene committee must be reactivated, and hygiene in the hospitals need to be improved. Next slide, please. Then I continued to other locations in the same hospitals and found these needles hanging on the IV bag on the IV stand are shown in the pictures on the left, and these improvised safety box sitting very close to the needle. Healthcare workers could not place the needles right into the safety box after use. Next slide, please. And this was what I saw when I walked to the back of the hospital trying to see their waste storage area. Infectious and non-infectious waste was mixed and stored in an open space. Any patients or their family members or animals could access this area freely. Next slide, please. One last thing before I wrap up my talk and welcome your questions. This is a picture of a bucket used to disinfect reusable medical equipment in one of the hospitals I visited. As you can see, without clean and safe water and good hygiene on the bucket, it is impossible to have effective disinfections of these medical equipment. I hope you are convinced by now that WASH and IPC should work closely together to improve quality of care and to prevent cross transmissions in healthcare settings in developing countries. Next slide. So what are the key take-home messages? Firstly, WASH is the basic need for IPC in healthcare settings. For sustainability, national IPC and strategic plan for IPC must include sections on WASH. And we should not wait until there is another epidemic to do that. We have to take actions now. And lastly, there should be collaboration between WASH and IPC at all levels, at international level. For example, WHO, CDC, and UNICEF. And I see that this is now happening, at least at CDC. Our IPC team is working closely with the WASH team, and I see that it's also happening in other big UN agencies. At national level, IPC working groups should include representatives from WASH. And at facilities level, and again, this is also happening in many countries that we're working in, IPC and WASH working group are integrated. In the facilities, they revise their job description, the hand hygiene committee job description, to include IPC activities. I think this is my last slide. Thank you.
Thank you so much. Thank you to all of our panelists. I think that these were really nice presentations that were pretty diverse perspectives. I think that some themes that I saw definitely were that there needs to be community level engagement, and that strengthening healthcare systems is critical to preventing future outbreaks. We know that there's a grave lack of WASH and healthcare facilities around the world, and so from Ebola to preventing other illnesses and diseases, improving WASH in the healthcare sector is certainly something that's important. Rather than take time to kind of do a more in-depth wrap-up, I want to open our last few minutes up for questions from participants. So please feel free to either type in the chat box or to, I think you should be able to unmute your mic and ask questions directly. I think that there was a question for global communities on if the program had any urban components. So I don't know, Alice, if you can hop on your mic and just answer that question about if it was purely a rural-based program or if there are any urban.
Sure. So the main activities were in Bang, Mofa, and Nimba counties, largely in very rural communities. However, toward the end of the IWASH program, we did start getting closer to more urban centers or peri-urban centers in those counties, for example, Banga. And so what we did was divide communities into smaller subsections, and that allowed us to trigger in smaller groups and allow for more effective monitoring. That's something that we were just doing at the very end of the program.
Okay, great, thank you. And then another question from the chat box is, global communities, you said that there's obviously a link between low Ebola and increased ODF. But UNICEF mentioned that Handwashing is fundamental. Is there any sort of comment on that?
Maybe I can jump in. I think the correlation between ODF community and non-Ebola is not necessarily related to the presence or the absence of excreta, but the empowerment of community who pick up other preventing and protective behavior, who are able to manage themselves to ensure appropriate, that people respect the messages such as not attending burial or not touching other people. So it's more this empowerment than the absence of excreta, and that leads to not having Ebola cases, in my opinion at least. I didn't want to undermine the usefulness of hand washing with soap. I was just mentioning that for Ebola as a specific disease, contrary to more orophageal disease such as cholera, for example, the only use of hand washing is not a sufficient protective measure. As we can see, when people are in contact with Ebola patient, they need this PPE, protective equipment, while when you get to cholera center, for example, staff don't wear any protective equipment, they just wash their hand with chlorine, and it's a sufficient protective measure. So I did not want to undermine the use or the prevention of hand washing, but saying that contrary to what we are used to deal in outbreak, which is cholera, typhoid, hand washing is not the most critical behavior.
Yeah. Okay, great, thanks. And then I'm wondering if each of our panelists could just give a couple seconds to the question of sustainability of what have you seen, what do you expect to see in terms of sustained hand washing behavior change?
Sure. So I would just add that I think in our CLTS model, we're continuing to do verifications and certifications, which take a year to do. And certainly, I think we have seen, some more lax practices in hand washing as the threat of Ebola has declined, and that's something that we're working with our natural leaders to continue to really promote those practices, even when the threat of Ebola is less evident.
Hi, for IPC. Hi, for IPC and WASH, we will continue collaborations at CDC, and we bringing in an environmental engineer to our group. So we will continue working closely with the WASH group to assure sustainability.
Great. Well, we are out of time, unfortunately. If you have any further questions, you can find the contact information for panelists on this slide, and then also feel free to reach out to the PPPHW. I want to thank our great panelists for preparing their presentations and sharing information about their programs. I think it's really important that we look at what was done and what we can learn going forward. So I hope that we were able to catalyze thinking around that topic. And then also, I just want to give one final plug. Global Hand Washing Day is October 15th, and it's a great opportunity to promote hand washing with soap in healthcare facilities, schools, and communities. So please do check out our website for information on that. And please be in touch if we can provide any additional support. And then last but certainly not least, we will post a recording of the webinar on our website, so please feel free to share that with any colleagues who might be interested and were unable to attend. So thank you all, and we hope to see you on future webinars. Take care.